What I wanted to do was very quickly go over this anatomy thing so that you guys understand male or female doesn't make a difference when we're talking about anatomy for injection. Everything else in life, big difference. But okay, we're talking about this over here. Now, he had one, as Kent always says, he gives his patients, that's my computer, don't worry about it. Kent always says he gives his patients one task to do, one bit of homework. Okay? You don't want to make people look different. That's probably one of the worst things that you can do, because if people, if their friends look up and say, you look different, what's going on? You look different. No, you want them to say, wow, you look great. Never seen you look better. That's the type of thing that we're trying to do, is the best version of whoever we are. If you take a look at him, damn good looking dude. Okay? Look at the strong male features on that. This is the first time I'm seeing these pictures. I wouldn't have never let you leave Montreal. We could use a little upgrade on our looks over there by holding on to a guy like this. Beautiful. Look at the beautiful male features, square face, a chin that's the width from iris to iris. Okay? He does have strong lips. He's got the beautiful jawline. I mean, everything's happening over here. Look at the angles. It's beautiful. And he's maintained himself great. How old were you here?
This is a typical Canadian.
22, 23.
This is an average
So
Canadian.
we're talking 20-something.
Average Canadian?
Yeah, sure. 20-something years afterwards, and the boy's still doing great. Okay. So let's very quickly go through it. I told you the aging process, what happens is we become a little more convex, and I'm going to turn his head. Look at the convexity of the upper part of his forehead and the way that he's starting to flatten out in the super brow area over there. He's starting to get a little bit hollow. Now, it's still a masculine look. We're going to treat it because he said, he gives me green light on this stuff. So I want, or now he just found out that he gave me green light on this. So that's how I found out how my kids are doing. I listen to my wife talking to other people, and then I say, oh yeah, they're doing that. I'm just sort of like third party on it. So we're going to treat a little bit of this area over here. Sure. We're going to treat a little bit. What color is this?
Brown.
Brown is good.
See it?
He's browned already. You've been hanging out in the sun here a little bit, buddy. We're all usually, okay? If we were to talk about an area of a little bit of volume loss, do I want to make him perfectly smooth or perfectly flat? No. What I want to do is I want to soften some of the heavy brow area over here, because one of the stigma of maturing is getting this type of thing and starting to end up with a little bit of hollowing on the temples as well, okay? Getting a little bit narrower for him over here, okay? So we're going to talk about treating those areas. So let's talk about the anatomy of the upper forehead over here, because can you raise your eyebrows for me, please? There's his lines. Relax now. Beautiful. So if you were to treat him with neuromodulator over here to try to soften those lines, is that anything that you'd like to do? Why? Going to drop his brows? His brows are pretty heavy right now. You see how men can get away with that flat brow from 0 to 5 degrees? It just, gives them a sexy look. But, yeah, girls are growling a bit here. Don't worry. We have little traps over here. They'll get stuck if they try to come up. Okay. So, yeah, I agree. If you were to treat him with toxin over here, we know that if you look at the functioning of the frontalis muscle, there can actually be 2 centimeters of excursion of muscle in this area, but only 0.8 in the upper part of the forehead, which is why when we treat the upper part of the forehead, we don't drop the brows, but when we get closer to this area, we do drop the brow. So wouldn't it be great if we could put filler in here and toxin over here? What a beautiful marriage and combination. The problem is that everybody's terrified when it comes to periorbital injections or anywhere near the eye, because of these issues that we heard about before of visual problems, which won't happen, visual problems, or any type of skin issue problems. But if you understand the injection anatomy, which refers to what? Depth. If you understand the injection anatomy of the area, you'll stay in the safer zones, right? So we're going to take another quick pencil over here. And what you can do in the meantime is you can prepare. What have we got here?
A white one, Arthur?
Yeah, a white one would be
right
great.
Here.
We're going to use some Refine for that.
Here's your white one.
Perfect. I'm going to backload some Refine.
Do you want to do...
Okay. So what I do, and I do this in my office too, but if, don't be afraid, like I said, to pick up a pencil, is we're going to mark out, you can almost see it on him, we're going to mark out the temporal crest.
Want it in the BD2s.
Okay? And that's always palpable.
I'll do it for you. I'll show you.
Yeah, show me the first one.
It's always palpable best at the eyebrow level. It's where it's thickest. So if you have trouble picking it up over here, he's pretty flat over here, you can pick up the crest lower down over here. So you palpate out the crest, and what we can now see is that in 98% of individuals, the frontalis muscle will run from crest to crest, okay? And very few fibers, only 2% of the population will fibers actually cross the crest and end up superficially in the temporal fossa. Can you raise your eyebrows? He's not going to be one of those because you can see any movement that he has. That's great. Thanks, Ryan. Any movement that he has in the tail of his brow, the tail of the brow, the only elevator for the tail of the brow is the middle brow. That tail of the brow is hanging there like a diving board. Okay? It's cantilevered. So that if he lifts the middle part of his brow, the tail comes up. There is no elevator of the brow over here, except in a couple small percentage of patients. They can actually have a couple of fibers here. And those are the ones that will spock on you. Even though you went all the way here with your toxin, they can still spock on you. Okay? So I would love to be able to fill this area. The problem is that he's got blood vessels that are keeping him alive there, and we have to understand where they are and what depth they're running at. So there's 3 main vessels to the forehead. I told you guys are going to get this. There's 3 main vessels to the forehead, really, that are of major concern. There's the supraorbital artery, supratrochlear artery, both continuations of the ophthalmic artery inside the eye, inside the orbit, I should say. And there's a branch of the superficial temporal called the frontal ramus branch that comes across that in most cases joins with the supratrochlear, not with the supraorbital. Okay? So the question is, if we have all those vessels over there, we're worried about it. Can I have a red one, please? How do you find them? I'm going to give you the easy squeezy way of doing this, okay? You have the patient look forward. That's, boy, just look straight ahead, right? You take your pencil, you don't draw on his eye, but you take your pencil, and you go for where the medial iris is, and we go straight up where the medial iris is. I'm going to do this sort of off the monitor, so because I'm not looking at him, I don't want to block your vision. Can I have maybe a red one that writes? Yeah, I'll do it that way. Oh, that's okay. I'll just change it a little bit. Okay? And if I put my finger over here, I'm right on his orbital notch. The problem is that only... That's great. Yeah, that'll be great. Thank you. The supraorbital notch is only present in 80% of people. 20% have a hole there instead of a notch, and you can't feel it. But the cool part is 100% of people, not 99% and not 95%, but 100% of humans have the supraorbital artery coming out within 1 millimeter of the inside of the iris. That inside iris line. That's why I told you have to look at that soft tissue marking. We're talking about the bony landmark here and the soft tissue marking of the inside of the iris. That was a study done by the Chinese on over 2,000 cadavers of different nationalities and ethnicities and races, and it's the most consistent finding in facial anatomy is where that artery exits. Textbooks will show it at the medial pupil. They're wrong. It's medial iris, within 1 millimeter. And as it exits, it has one thing in mind. It's got to supply the muscle, soft tissue, pericranium, and the skin of the forehead. And so it's going to head north, like this. You okay? Would you like something behind your head, maybe? A little pillow? You're good? I'm holding it sort of over there and loving it, but okay. Let's not go there. Okay. So it's going to head north like this. And it's going to give off branches. Underneath the frontalis muscle, there's something called the galea. The galea is a thick fascia that's underneath the muscle. Why is it there? Because the forehead muscle is really a muscle of facial expression. The muscle has to glide. It can't be stuck down to bone. So there's that galea that it glides on, and there's a subgaleal space, a little gap in between the galea and the periosteum, which is the covering to the bone. And that's where the movement occurs over here. It slides up and down like that. The artery, as it comes out, within 1 centimeter, in all cases within a centimeter, perforates through the galea. When we do forehead lifts and we peel the forehead down, we take a look and we can see the artery coming out of the bone, and right away it wants to get into the complex of muscles over here to supply the muscles with blood. And so it pierces the galea and then starts to ride up the forehead like this. Okay? When it rides up the forehead like that, it's struggling to get to the surface of the frontalis muscle. Because if it's sitting on the surface of the frontalis muscle, underneath the thin fascia on the top of the frontalis muscle, it's able to send perforators down to the muscle and up to the skin. So that's what it does. That's the supraorbital artery. The supratrochlear artery, which is its sister, is more variable. She's the nasty sister. She's the one you have to really look out for. Okay? The supratrochlear, how do we find that? Well, I was told by some of my plastic surgical colleagues that when they do their forehead lifts, their forehead flaps, like I used to do when I started in practice with Dr. Millard, we would base the forehead flap on the supratrochlear artery to reconstruct the nose. We were always doing Dopplers to find that supratrochlear artery. And one of my colleagues mentioned to me, he says, I don't even bother doing that anymore, because what I do is I automatically assume that it's underneath the medial crease of the corrugator, right here. It could be 8 to 12 millimeters more medial than the supraorbital, okay? It could be anywhere, but it's underneath that crease. So I looked in the literature to try to find substantiation of that. I found one article that talked about the fact that there was something with relation to the midline and how you can find it and all this. So what I did is the next time that I was in a cadaver lab with 30 cadaver heads, I dissected out the medial crease on all 30 cadaver heads. And within 2 millimeters, the one I found that deviated a little bit was 2 millimeters laterally, but that crease is pretty much dead on where you're going to find the supratrochlear artery. So you have the patient frown, and then you can see where that artery is going to be. If it's a patient that already has neuromodulator there, then you squeeze the forehead like this and see where it breaks. Because Rod Rohrich and Joel Pesta have shown us that where there are creases, there's typically an artery that's sitting underneath the crease, especially in the nose area. So that artery comes out around the bone in most cases. You won't be able to feel a notch or anything about it. Sometimes there's a teeny little thing. And it's also going to head north and do the exact same thing like its sister. It's going to perforate through the galea, get into the muscles over here, and then it's going to end up on the surface of the bone over here, on the surface of the muscle over here, the frontalis. Great. Problem is I don't know whether, with the variation from person to person and patient to patient, I don't know whether that vessel is doing this, or whether it's doing this, or whether it's doing this and jogging to the left. You can't tell. There's too many variations. What's the thing that I'm worried about? What do I have to look for? Depth. The thing that's consistent is the depth of which these vessels pass. Within the first 1.5 centimeters, where you see the black line over here, within this area, any other color of the black maybe? Okay, from here to here, and coming across to its friend on the other side, that vessel is going from deep to superficial. And there's a study that's shown that it's variable in the way that it does that. It can perforate right up to the surface and then run along the surface. It can go at an angle until it gets to here and then run on the surface, or it can stay deep and then come up. Okay? I can't tell. The one thing I know is that it's not on bone, but this is going to be a high-risk area for me to wander into with a needle. If you're a excellent injector like Kent, if you're using a BD2 which has very, very consistent small little amounts of deposits, you're understanding where these vessels originate from. If you have to do a little bit of work to go ahead, especially on a female, to give them a little more volume over there, you go down to bone and you stay on bone and you give a small little injection and you watch it. The way that I personally like to do it in this area is to use a cannula and to go from a lateral approach. If I have to give volume there, he doesn't need it. As I explained to you earlier, by going laterally with a cannula, I could be in and out of the artery if I accidentally enter into the artery. But if I go vertical like this, which I see people going ahead and doing cannulas in this direction, it makes me very nervous. So this is an area that you got to be very careful. It's a relative no-fly zone. If you're a skilled injector, like I said with Kent, you watched the way he was doing with his little BD2s. That's the way I would do it. I wouldn't use a large needle here. I wouldn't use really anything. 30, even a 30 gauge. Why? Because the artery over here is on average 1.8 millimeters big in diameter. And from skin, feel yourself, from skin to bone here, it's maybe 2.4 on average. That leaves you 0.6 millimeters of play. If you use a vertical approach, which we do, and you put in a needle that's a 27 gauge needle or a 25 gauge needle, if you're using something that you've wanted to use a little bit of a more robust product, the actual bevel of the needle might still be sticking in the artery even though you're touching bone. By using a BD2, you are guaranteed, as safe as possible, that your needle is sitting on bone with very little play, very little bevel that's exposed above it. Got that? There was just a study done by one of my friends who was insisting, saying, Arthur, don't use needles here, because we showed in the lab that we used a needle and we were able to flood one of the arteries with a needle when he was using it up over here. I said, you can't. He said, no, we think that we pushed the artery down to bone because the needle was dull. I said, that doesn't make sense. It just doesn't make sense. It's impossible. And then I said, well, what size needle were you using? And he said, well, a 25 gauge. I said, I would never use a 25 gauge in the forehead to begin with, because the bevel is going to be inside the artery regardless. You don't have to push it down to bone. There's just too much of a bevel. And there's different types of needles that you can get. You can get dermal needles, and you can get other types of needles that have a shorter bevel on it. The BD2s are the ones that are the shortest, which is why I like to use them on the forehead. So getting back to what I was talking about, this is an area to be careful about when you're going in. It's a no-fly zone. I personally don't like to put any needle under the skin unless it's a BD2 over there, and if I do, it's going to be on bone. I will use a cannula because we worry about retrograde flow here. But in the entire other forehead, the rest of the forehead going from here up, the bone is relatively avascular. My plastic surgical colleagues will tell you that when we do forehead lifts, whether we do it in a subperiosteal or we do it in a subgaleal plane, it takes 30 seconds to lift the entire forehead because there's no vessels. There is a periosteal vessel that's associated with the supratrochlear called the supratrochlear periosteal vessel, but it's a short vessel. It's very, very curvy. It's very small, and the chances of you causing a problem by going in there are very, very slight. But anywhere else across the face, across the forehead over here, if I want to give him volume over here, what I am doing is I am going with a needle down to bone. Small needle down to bone, or as Ken showed you, cannula from the side. And we can talk about the difference on that. There's only one other thing that you have to worry about on the forehead. And that is there's a nerve that's associated with the supraorbital nerve. There's a deep branch. All the nerves that come out from these two areas follow the arteries, except for one. It goes its own direction. It's really called the deep branch of the supraorbital nerve. I call it the Rhonda branch. That's the name of my wife, because she goes wherever she wants and you can't convince her otherwise. But this nerve, this nerve that's over here wants to do this. Okay, if you can see it a little bit over here where I've traced it. This nerve, what it wants to do is it wants to get to the back of the head to supply the back of the head with sensation. And because of that, it stays on the periosteum all the way to the back. When it stays on the periosteum all the way to the back, it is consistent in being about 1 centimeter to 1.5 centimeters inside or medial to the temporal crest. If you stick a needle down on bone over here, he's going to say ouch, and he's going to feel the pain back here. And if you pain him, you don't retain him. And I'm looking for a good experience. There's also a small artery that's associated with that nerve that I've actually seen a case referred to me that had a slight skin problem over here from an injection that was put in over there. So I'm careful not to go in with a needle down onto bone over here either. If I have to treat that area, it's either with cannula or pushing the product with my thumb or finger medially. So don't go under the skin here because you hurt the patient. Don't go under the skin here with a needle unless you're using a BD2 and you're going in between the areas and you're being very, very careful with it because you might blind the patient. Everywhere else, it's open game on bone, as far as I'm concerned. Needle versus cannula. Cannula, as Ken showed you, you come in from a lateral approach because you want to cut across these vessels. So you come in from a lateral approach. I don't want to see anybody going in from perfectly above. You can come in from an angle if you like over here. But you come in from a lateral approach like he did. You can start from here. You can start from here. It's a question of negotiating the curve of the skull at that point, whatever you feel more comfortable with. The difference, I think, between needle and cannula over here is just one simple little thing. I know I'm on bone with that little needle. And when I inject, I'm injecting not only my product, but I'm injecting lidocaine as well. And the lidocaine stays under the galea. And as I'm going to inject on him, you're going to see that he's going to maintain movement of his eyebrow after we inject him because the lidocaine doesn't make it through the galea. It stays in the space. If you go down with a cannula and you're using a 25 gauge cannula or bigger, 22 gauge, 25 gauge, it's difficult for that cannula to get through the thick galea, and where you're depositing your product is really between the galea and the muscle. Now that's a safe zone because the artery has already come up and is lying on the surface over here. It's a safe zone. But the problem is the lidocaine is going to affect the muscle. So when I've demonstrated a 25 gauge cannula on this side and a needle on this side, we get the same beautiful result, except when I ask him to raise his eyebrows, this one moves and this one is stuck. It stays down for about a half an hour until the lidocaine wears off. And I told you, I'm all about experience in my practice. I want them to go out right afterwards and to be able to meet their friends. Either one is fine. I'm not going to tell you if you are used to driving a car a certain way, don't change the way you drive because of me. Use a cannula if you're comfortable. Use a needle if you're comfortable. But as long as you're on bone, you're going to be okay above this zone. And that's the whole forehead. Let's clean him, and I'm going to start to inject his forehead, and then we're going to go on to temple anatomy. Are there any questions about the forehead? There is a little question coming from the front here. You're going to have to speak loud because I don't think I see a microphone.
So now that we have glabella, would you fill in fine edge glabellar creases?
That's an excellent question because I forgot to tell you about that. What do you do in that situation? What happens in the situation that you treat a patient with toxin for their glabella and you find that they are not moving, but they have the ingrained crease over here and you want to soften the crease? Can you inject with a needle? Because you can't put a cannula into dermis. It's impossible. You probably can put a 30 gauge in, but that would kill. It's like putting in a dull needle. So how do you treat those glabellar creases? You can use a fine product in the glabellar crease, but you must make sure that you are intradermal. You have to be in the dermis. I told you, 2.4 millimeters, 1.8 for the vessel. And you're going into the crease where the vessel is right underneath it. You have no play there. So as you inject, and I use BD2s for this as well, as you inject, I have a control of the BD2, I'm injecting. If I lose the pressure on the plunger, if all of a sudden it becomes very easy to inject, where am I? Subdermal. So I will not inject. I'll back out again and I'll go into the skin. You must feel pressure. If you're going to rely on the fact that you can see the tip of the needle, you'll end up with a Tyndall effect. You're going to end up leaving little bumps that are too superficial in the skin. So you have to go on proprioception for me over there, but you can do that. That's a good question. I forgot to mention it. Thank you. Okay. So I'm going to use on him. Yeah, let's do some BD2s here. And pick whatever product you want me to use, Ken.
We got Refine.
We got Refine.
Fine.
So Refine is a great product.
Straight up.
Yep, straight up Refine. Perfect. How can I use this on him? Because of the fact, maybe what we can do we have another blanket? We'll give him something, because then you guys, if he puts his head back, can you guys see this? Yeah, maybe not so bad. We have another pillow there?
Pillow.
Yeah, so maybe we can put a pillow.
Yeah, just get the pillow from the other side there.
Here we go. I think that might be difficult to pick up. Let me see if
we'll
this
just
makes
put it under here so that it doesn't reflect light.
Okay. We're going to try to give him, we have one pillow that's there already.
Going to keep it there.
Maybe we can use this one. Go ahead. Why don't you come back now and try sitting on this and see if that's a little better, if your head's a little better? Not too bad. You okay?
It's too flat.
Okay, he looks pretty good on the screen because we're coming in from an angle. So I feel for the temporal crest. You can leave it marked. In fact, what I'll do, just for demonstration purposes, is let me have a pencil, please, a white pencil.
White.
Go ahead and comment on anything that we're doing here. That's perfectly fine. Why have I chosen Refine? People always say, why do you choose the product that you're choosing? I'm looking for a product that has a little bit of oomph, a little bit of push forward, because he has thick skin. He's a male. Okay? It's a little bit deeper. I'm going to have to use more product if I was to go to a product like Silk, which I could do on a woman, or a woman who has a little more maturity to her with thicker skin, or with thinner skin. I can use that. But I'm thinking, okay, I'm going to use Refine because I'm thinking in my head already, I want to do this, and I'd love to be able to do something over here too to soften him up. I've already done some of his cheek. We'll increase maybe what we do on his cheek. So this gives me the opportunity to use one syringe to do multiple treatments. And we have a question with the hand up.
Arthur, would you mind, like, real quick doing the calipers on him?
Sure.
So we can kind of see, first of all, how that looks like on the man.
I was going to do it for the mid-cheek, but I can tell you right now that for the upper forehead, there's really not much calipers to... There's not much calipers to... can you hold this? Look at it. There's no cap on it. That's a girl. So if we take intercanthal distance over here, which is going to be a little wider, typically men are somewhere between 29 and 32 millimeters. Women are more like 28 to 30. But if you do that on a man, okay, what you're looking for, we're talking about mid-face, but you can even see in his situation... Let's get that distance there. Thanks, Ryan. That he's got a pretty good length to his eyebrow still. He doesn't have a peak on his eyebrow, which is a feminine feature. Where's the male peak, Ken?
I don't want one.
Right? He doesn't want one. If a man has a peak, it's going to be more lateral than the female. The female peak...
Don't create peak in men.
That's right. Just don't do it. If they don't have it, it's perfectly fine. It's almost like a gentle arc, and you look at him, it's literally look into the... Actually, you're pretty much centered over here. Let's see if I can get you tilted. I always have trouble with this. It's the wrong way. There it goes. Okay. You all right? Perfect. So if we take a look at it over here, we see that he has about a 5-degree takeoff for his brow, which is very nice. If I wanted to feminize him, I'd do that. If I wanted to Jack Nicholson him, I'd do that. Right? Okay. But you can see that's for the eyebrow. Okay? We can take a look very quickly because I want to really get into the injection aspect of it. If we take a look at his nasal length, and remember, a nose in a male is going to take off from the tarsal fold. He's a little bit short on his nose, so I think that even probably lengthening him a teeny little bit over here might be interesting. Yeah. Did you agree on that, Kent? He's got good nasal width over here. He's got good width to his lips. I just opened it up a bit over there. And that's the chin that I want on him too. Look at that. See the width of the chin? You saw that on his younger pictures too. He's actually lost a little bit of width on his chin. I didn't pick it up on him because of the little, I like this number 3 or 4 cut on here on the clippers. There we go. Okay? Right, the little clippers over there. So the question is really with facial width, men can stand a little bit wider faces because of the fact that they have a little bigger intercanthal distance. He's still short over here. You see the gap? You can see the gap here where my finger is. I think he can use a little more width. And the question is going to be, where is his cheek apex going to be? If we're going to put him up high over here, he's going to look feminine. And if I give him that apex where we were talking about for a man over here, that's going to make him look a little more masculine, and it's going to make him look good. Look at that. Isn't that nice? I should just walk around with my finger stuck on your face like that. It'll be perfect. So that's the kind of things we're looking for. The forehead, I told you, it's got to be scoped. It's got to be slanted.
That is chainsaw.
Yeah. So the forehead has to be a little more sloped. You don't mind to have a waggle on a male's forehead because I said it gives him a little more. The overall slope of it is a little more. And you don't mind having a little promontory, but you can certainly see where my cannula is that he's got a big... Turn your head a little bit more. I'll probably rip it off your body here. I don't want to do that. But you can see there's a gap. You see where the shadow is?
Shadow? See the shadow there?
There's a huge gap over there. You can see it. And so I just want to soften
it's not huge, but it's
Okay. Let me have the circle. But I'll go through it as we go along, okay? But that's a good question to ask.
I'm just here to, just keep him honest.
Pencil. That would be impossible. Okay. So I feel for the temporal crest. I see by what we drew out before where we have to give him injections, and I'm going to make little injections about 1 centimeter apart. Usually there's about 6 of them in a female, about 8 of them in a male.
Are you going to do the left side with a cannula, or are you going to...
Yeah, we can try that afterwards. We'll do one side with needle, and we'll do one side with cannula. Okay? There we go. And I can see, I get the impression there might be a little vein here or something. Let me mark out my crest.
There is.
Give me the cleanser. And what I do, by the way, guys, is because of the fact, and this is so important, we have to be super clean. What super clean means is the fact that these aren't sterile sponges. These aren't sterile gloves. The product, the actual syringe itself, is not sterile, even though it's bubble wrapped. It's only the product that's inside the syringe that's sterile.
It's fine.
Okay? So we have to be super clean. Every single gauze that I use on the face, and that's why you're going to hear about this now, has a little bit of chlorhexidine on it. Because I want to try to keep the bacterial count down as much as possible. So I will not even use a dry sponge. Even if it's a teeny little bit of chlorhexidine over here, I want to make sure that I'm constantly cleaning. This isn't an injection that we're doing. This is a relationship. He's going to have to live with this product probably for the next year. And if we start off on a dirty aspect in the relationship, it'll never go well, like any relationship in life. So you got to be super clean. And I can't stress how much you have to continually clean over here, okay? So I'll have the little bit of refine over here.
Another one, too. He'll need another one there, too.
Stabilize my hand, okay? I'll get you a good view over here. I'll turn him a little bit towards me so you can see the... And when I inject the forehead, what I do is I inject either perfectly vertical or maybe just slightly off vertical. It's the shortest distance between 2 points. I don't want to skim across the bone like this. And I'm looking to see if I can keep my bevel facing down so that if I do have a little bit of an angle, that bevel is definitely going to be in the place that I want. I retract the skin. You're going to feel a small little stick, Ryan. We've been through this before. And I let the skin fall back into the needle. And you can see the depth on him is going to be much more than the depth on our next patient who's going to be female. And I start the flow. Where am I looking as I'm starting the flow? 2 places. Syringe? Absolutely not. Do not look at your syringe when you're injecting. That's like looking at the steering wheel when you're driving a car. You're going to hit something. Look at the skin. Look at the skin where you're driving on the road. So I'm looking at the skin, and my rear view mirror, as I'm slowly injecting over here, my rear view mirror is this area right here, the glabella, because the glabella is end arteries. The upper part of the nose and the glabella are all end arteries. And if you have any type of issue that's happening over here, the first place that you're going to see it, even if you're injecting the chin, we'll see blanching over here if there's a problem. Okay? There's not a lot of help over here. So I'm checking here, just taking a quick glance over there. I'm looking at the actual place that I'm injecting, and all I want to do is create a small little bump, which you get after about 0.03. I'm now prepared with my chlorhexidine little sponge over here to pull out. I might have skewered a vessel. We're lucky. We didn't touch it. And then I just put a little bit of pressure on that area. That's all.
And remember, these are 31 gauge, 8 millimeter needles.
How you doing?
That are fused on, so they're not going to blow off.
5/8 inch? What's the length of the needle?
8 millimeter.
This one is 5 millimeters, or it was 8 millimeters, what you
That's
gave me.
8.
That's 8 or 5?
8.
I think it might be even smaller.
Oh, 8.
Really? Okay. Whatever he gave me, I don't know. He just gave me a
8
needle.
millimeter. BD2s with the 0.3 cc's are 31 gauge, 8 millimeter.
The advantage of also using these little BD2 needles, as I go to the next area, the advantage of using these little BD2 needles is the fact that after 3 or 4 injections, they dull. And you lose no product because there's no lure lock. Okay? You can see here, I'll put it back over. It's fused, so there's no product loss. You just toss the needle into your sharps container, and you've lost no product. And I got to tell you, I am a miser about every single little bit of product that I use. How you doing, buddy?
That's one reason we only transfer like 0.15, 0.2 kind of thing, because these are insulin syringes that are meant for one stick.
Small stick.
So generally, the needle is made by the low bidder, and they're not that great a needle. So you don't want to use it. That's why you don't repeat injections. So 2 or 3, 4 little injection sites is about max. So if you transfer 0.15 to 0.2, sometimes we'll do 0.3, but generally it's just 0.12 or 0.2. Yes?
There are a lot of ophthalmologists now that are recommending against the use of chlorhexidine on the face.
Correct.
Yeah.
Correct.
Yeah.
Correct. And I've stopped using it on the face when I do my surgeries. I used to prep with 0.02% of chlorhexidine, and now I've gone back to using Providine, which is a real mess in the operating room because it gets everything all yellow and everything. But I've done that because of a splash. Even in an actual ophthalmologist, there was an ophthalmologist who developed corneal issues and visual loss because of the splash of chlorhexidine. So you're absolutely correct, but these are just moist.
Yeah, This
is not a prep. This is just moist stuff. So I agree. That's a very good point to make sure that you're not using a pad that is drenched in the stuff that it's going to drip into the eyes. But you're absolutely right. Whoever made that comment, that's correct.
Do you guys have any experience with the AccuVein device?
We were just talking about that at the break. We've tried it on trying to locate veins and arteries in the face. It just doesn't work.
Yeah, we've tried it.
Just doesn't work well. I don't even know exactly how that thing works when it comes to actually putting in intravenousous and things like that. But we've tried it on the face, and we haven't been able to identify really the major vessels.
We've played with it. It's a bit of a nuisance to use. It's better from my experience, it's better to sit at eye level, good soft light, and you can usually see most of the vessels. And if you know your anatomy, usually most of the vessels that are important.
So what's the issue over here? The issue over here is that if you hit a vein or you hit an artery, you're going through it, behind it to inject it. The only problem occurs is when you remove your needle, you lose the tamponade effect of the needle in the vessel, and then what will happen is you'll get a bruise. That's why I'm always very quick to put a pad on to keep some pressure on the pad afterwards.
You can stop a garden hose with pressure,
So that's the idea behind it, and there we go. And the other issue is that you want the product to spread, so we're allowing a little bit of pressure. We're choosing a product that's going to spread across there. You can get a little bit of that roller coaster type of look that will last for a day or two if you're using micro injections like this. But the amount of product I find that I use for this is very small. They gave me 0.15 or 0.18.
Yeah, 0.15.
Yeah. And I've already done almost the entire hemi forehead. I got to do this part a little bit more over here. I just want to show you that when you look at him right now, you can see, there it is. Okay. So you can see, you can see that there's a slight contouring that's going on over here. Look at the line that's a little more prominent over here. Look how the line is a little bit effaced over here. Can you raise your eyebrows for me, Ryan? He still moves both eyebrows perfectly well, even though there's lidocaine in the product. So you can contour a forehead without causing a type of asymmetry or a type of dyskinesis, if you want to call it, or
what I would suggest too is those that are sort of still awake,
same thing,
and you'll notice that his left eyebrow is ptotic. His left brow is lower than the right. So when you're doing the filler to contour, because his left eyebrow, Arthur's a little bit lower, so you could raise his brow as you inject for contouring, and it'll actually raise that brow a little bit up.
So I've used 0.15. You can see where I stopped my injections. There's the last little bit of the dent that he had coming across. You can get that type of contouring on this side, okay? And if we turn him over here, you can see that he has still that little bit of indentation on this side over here. So he's not a really major case that I would concentrate on this. I'm using him more as a demonstration case to show the type of technique that I use in doing forehead contouring. I love to do forehead contouring. If you ever go out to Asia, it's probably the number one area after the nose that they're using fillers is to contour foreheads. They love smooth foreheads. There's a difference in the way that Asians prefer their contouring to the way that we do. We like the contouring where we have a little more fullness at the bottom. They like the fullness more at the top, if you see the way that their foreheads are shaped. It's just to know just something like that. Now, occasionally, every now and then, you're going to fire in. Can I have a little bit more of the product, please? Occasionally, every now and then,
There you go, sir.
Thank you. We're going to fire in a product, and maybe we're going to go into the little tiger country over here, and we're going to see that we're going to put in a little bit of product. We're going to inject, nice and slow.
Notice his little distraction twitch. I mean, that's something that all should learn how to do that in all areas. It's very, very effective rather than squeezing someone's toe.
I never saw that before.
Yeah, it's better to have a little.
BLT cream on him before you started injecting?
Nothing. I don't like to put any cream on my patients beforehand. I only do it psychologically for those patients who are are dependent on it, are attached to it. I have 2 patients left in my practice. He does. I don't. But
I'm in Western Canada. My patients are wimpy. So actually, the only reason I use it is not because they're wimpy. They're actually great. I use Prilocaine with it, so it creates some vasoconstriction. So they have less chance of bruising, and particularly around lips, they don't feel a thing.
I don't do it because I got into the habit of not using it on stage because there is a tendency for the face to look greasy, and I can't write on the face with it. That's number one. So I let them suffer on stage. But he's a good guy.
Just take it off.
That's it. And the other thing is that you can get a rebound, hypervascularity rebound, where they look a little bit of redness during the time that you're starting to do it. All of a sudden they start to look a little red. So I just got used to not using it, and I rely more on my injection technique to keep myself from being painful. You'll notice that what I do is I'm flicking the skin as I do that, but what I'm actually doing is I'm driving the skin into the needle instead of the needle into the skin. So that when I inject on a cheek, I'll pinch the skin up at the same time that I'm moving the needle down so the skin comes up into the needle. If you're going to try to commit Harry-Carry, I suggest that you fall on your sword and you don't stab yourself.
You probably didn't feel that much on your forehead, did you?
Barely feel it.
Yeah.
Barely feel it. They should barely feel it.
It's just a little technique.
I always ask patients, I said, if you grade it from 0 to 10, where 0 is no pain, and 10 is you want to punch me or run out of the room, you would call that a 1?
Well, it's not pain. It's
just it's there.
Yeah.
So they'll say 0 to a half, but as long as they say a half, it doesn't mean it's painless. It just means minimal discomfort.
-1, he's asleep.
And men are the worst, huh?
Oh, yeah.
If it was up to us to give birth, we'd got extinct by now. You can do intradermal injections on the forehead to chase deeper lines, but please make sure that you're in the dermis, because right under the dermis are the vessels. The vessels are literally under the dermis. And if you take a look again at studies that were done on people who thought they were injecting intradermally, they were subdermal with most of the injections. So you can do that. You can trace. You can use a little bit of a longer needle and trace it along like Steve Fagan does. He hyperblends his products when he's doing that. He has a 5-to-1 ratio where he puts in 5 cc's to 1 cc of product. If I'm chasing a little bit, and this is, let's say, we're fine over here, and let's say you have a patient that comes back, actually, is that a little scar you have over there?
He's got a little scar.
Yeah, he's got a little scar over there. So what I would do in a situation like this is I would let the skin fall back into the scar, and then I would just basically inject over here. And I'm making sure that I feel pressure, which there is on the syringe, to be able to inject a little bit of that. Okay. This is pure.
This is straight up.
What's the longevity of Refine and Define as opposed to Vicross?
What's the longevity as opposed to Vicross? That's a very good question. I never compared it to the longevity of Vicross. But I would say that probably in the studies I think that they did, they found about a 12-month duration. Yeah. I think that's what you're looking at. So you might be able to get a couple more months out of Vicross, maybe a 14 or 16-month type of thing. Although, they say that it's that, look, that scar is now gone.
Can you speak to the hydrophilic nature of the Refine and Define compared to Vicross?
To me, I think the product, it depends on its cross-linking, but it does swell a little bit more than the Vicross. The Vicross is probably the least swelling of most. Bella will absorb about 100% of its weight in water. Volure, which you'll be getting, which is Volift, will do about 125%, and Volume about 150%. It depends really the swelling that occurs over here, because this is done through the sheath, through the grid, where they're pushing it through a sieve, and they're getting different size particles, always at 20 milligrams %. That's the constant that you have with all these products, the Refine and Define. It's 20 milligrams % passed through a sieve, different size particles, different cross-linking, but there's some free HA that has to be incorporated on it to have the rheology. That's what swells more than anything else. There's a very small amount of it. But I think if I was to look at it, the swelling would be somewhere between Restylane and Restylane Lift, which is a little more of a swelling thing to me. Certainly less than Ultra or Ultra Plus, because those swell to 500 or 600% of what they have. They can really absorb water, and not as non-swelling as the Vicross line. But I don't know exactly the amounts. I wish I could tell you. I don't know exactly the amounts, but you can certainly ask. They'll show you studies to try to show that.
In my experience, when you blend, you tend to decrease the amount of swelling you see later.
Right. Now, why is that?
You're rehydrating.
Bingo. That's the whole idea, what we were talking about at the break. you're putting in the wet sponge instead of the dry sponge. You're giving the product what it's looking for is fluid. So the tendency is that there'll be less. This is why that normally in the periorbital region, I only use blended product. That's just my particular way of doing things.
I just use blended.
And it's a 50-50 blend because I want to hydrate the product so I don't get surprised by late swelling on it. Okay?
What is your product of choice?
For what?
Period.
Good.
Yes.
Hold on to this.
It
We're going to do some
depends.
periorbital stuff. I'll do a little bit of stuff on him just to show you. Let me just take a look at the temple anatomy because we want to move along so I can get to another patient to inject. Let me have the
What do you want?
the pencil so I can just mark it.
What color?
Any color. Again, we're looking for palpable.
Here's your
This
white.
is the crest over here. We palpate the crest.
We can answer your question about the orbits here in a bit.
Yeah, we're going to get to them and I'll tell you
We'll
what
get
I
to that
use.
next patient.
For sure. Okay. There's the crest. Temporalis muscle. Temporalis muscle. Let me take a look at him and see if there is a little bit of asymmetry. Okay. Temporalis muscle is a muscle of mastication, right? It's a muscle of chewing. It's not a muscle of expression. So it has to have a lot of force that it can generate to pull up on the coronoid process of the mandible. That means that that muscle is attached down to bone over here. It has to have anchorage down onto the bone. And it's anchored so tight down to the bone that there's no fascia underneath it. It's muscle into bone. If you try to elevate the temporalis to do a temporalis flap, they bleed like stink when you try to pull it off the muscle, off the bone over here. What happens is the galea that's coming across over here, which is under the frontalis, can't get under the temporalis because it's anchored to bone. So where does it go? Over the top. And then you have an anatomical oddity, a misnomer. We call it the deep temporal fascia. But guess what? It's on the surface of the muscle, not under it. So what you end up happening is you have the muscle, which is the peanut butter or the bologna that's down on bone, and then you have the two pieces of bread in the sandwich on top, the deep and then the superficial temporal fascia. In the deeper part of the superficial temporal fascia are where the major vessels are. That's that branch I was telling you about. That's the frontal branch of the superficial temporal artery. You can practically see it on him, and you can put your finger on it, and I have my finger on his pulse right now. They're all riding on the surface of the deep temporal fascia. Underneath the deep temporal fascia is the muscle in this area. As the muscle starts to fan, as the fan starts to narrow down to insert into the coronoid process, so you can get pulling on your mandible, it picks up a fascia on the posterior aspect of it, on the back side of it. It becomes a fibrotendinous insertion. But there is no fascia under the muscle here to speak of. So you have to find a place on bone that's not only devoid of fascia, but devoid of blood vessels too, to the most part, the safer area. The deep vessels of the temple are branches of the internal maxillary artery, second division, that are from here. And those are the anterior and posterior deep temporal arteries. The one that you have to worry about, where I put my injection, is the anterior deep temporal artery. That anterior deep temporal artery is starting from here, and as it works up, it's getting smaller and smaller and smaller and smaller. So by the time you get up to the top of the temporal fossa over here, it's a thin little thread of an artery in most cases. But there are variants, right? The one thing it isn't is on bone, and the other thing that it isn't is within 1.8 centimeters. That was a study that was just done recently by Dr. Kim. He's an anatomist. Heejin is a friend of mine, an anatomist from Korea, where he did a study looking at those temporal vessels and where they're located. They're no closer than 1.8 centimeters from the orbital rim. So if you choose a position 1 centimeter up and 1 centimeter over like this, and you find your sweet spot over here, that's 1 centimeter up the temporal crest, 1 centimeter parallel to the orbital rim, as if you're making a little box over here, this to me is the sweet spot for injecting a temple. Because when you put your needle in, you're going down onto periosteum, which is practically avascular in that area. You start the flow of product. The product that you're going to choose is a product that you want that can stand up and at the same time spread. We could use Refine. We could use Define. We could use Voluma.
Lift.
They don't have it yet, but Volift would be another thing that you could use as well, right?
Yeah, right.
So you can use that. You can even sometimes use Restylane Lift if you wanted to. Depending on how I choose my product for a temple depends on what the anatomy of the temple is. If it's somebody who has a deep fossa over here, but it's very, very limited in its circumference, I want a product that's going to stand up like this. And so I'll use a product that has a lot of G prime, and I can use Restylane Lift for that type of thing. I can use a product like Voluma for that. If it's a situation where it's a shallow dish, where you have just a hollowing all the way down and I need a product that will spread a little bit more, then I'll go to a product like Refine, or I'll go to a product maybe even like Ultra or Ultra Plus. I'll vary my products according to what I'm looking at over here, thinking, am I right or wrong? I don't know, but I have at least a reason for why I'm sticking a needle in the patient's face beyond just thinking in terms of volumizing, okay?
Blended.
Very often I do blend in the temple, but a lot of these products now you can use straight up because they've already been blended to the idea. I mean, what they got the impression is that when we started blending products, maybe they should give us the blended product originally, because that way you know for sure you're not contaminating it when you're blending it.
I use them straight up for here.
Yeah.
It looks like he's more than a centimeter up and down, but it's more feel, proprioception
Could
than
be.
sight.
Could be when I marked it. We'll just take a look. Yeah, might be somewhere just about over here. It's hard to tell.
Yeah.
Could be. Just tell me if I seem, because I'm trying to look at a monitor and look at him at the same time. So when I inject over here, what I do is I go down to bone. It's not very much depth over here. It's going to be 3 or 4 millimeters of depth. Whatever you give me is what I'm going to use,
Okay.
Kent. You tell me why you choose it and why, and I'll just inject it.
Here you go.
I'll take a cleanser.
The only time I look at the amount that I've got is the amount there, but I'm like Arthur. I don't ever really look at the syringe. I just go by what the face tells you. But he's got 0.2 cc's there.
Right. So I have about 0.2. To be honest with you, a typical temple for me would be anywhere between 0.3 and 0.5, because what you're doing is you're creating the pillar and the canopy at the same time with one single injection point. Okay? You're letting the product ride up through the thinner fibers of the temporalis muscle here. They're very thick down over here, but they're very thin over here. You're allowing the product to ride up. And then when we take a look at the anatomical dissection, I'm not going to open him up to show you, but we're obviously, when we do this in the anatomy lab, we see the product hits its head on the deep temporal fascia and spreads along it in the plane of least resistance. And so it ends up going exactly where you want it to go, because you've married the science of the product to the anatomy of the region without moving your needle. It's a vertical puncture.
Can I just show one thing?
Please.
So if he was a female patient and you wanted to lift the tail of the brow, then as I inject this Swiss spot, which is that 1 centimeter below the temporal fusion line, 1 centimeter above, I actually, as I inject, raise the brow and inject that, give that strut work and support. And then if you're going to need to do that, you need something that's got some jam, a little lift.
A little oomph to it. Correct. I'm doing this more for demo because he doesn't need a whole bunch over here. Maybe we'll just contour him just ever so slightly. We'll see the effect that it has on his eyebrow. And most of the time I use a 30 gauge needle. That's the 1/2 inch needle. Thank you. Okay. So Kent gave me a BD2. I'm going to use the BD2 just to show you that you can get down to bone there. Point in fact. If his depression was here, do not stick a needle in over here. You can put a needle in 1.5 inches over here. You'll end up in the pterygopalatine fossa. I've had a patient referred to me with a palate necrosis because they caught the senopalatine artery. Don't do that. If you want to inject over here, you either inject here and allow the product to come down, or you can use a cannula and go more superficially over here. I suggest that you do not stick a needle under the skin over here, because you really can hurt a patient over here, and you're going to waste a lot of product. You're going deep into the fossa. The other issue that occurred with somebody who tried to use a cannula deep over here happened in Germany. This ain't going to happen to you because we're not doing it. I'm just talking over here. Is they penetrated through the skull into the brain. They were using a 25 gauge cannula. They were trying to get through the deep temporal fascia, which is very thick, and when they pushed through what they thought was the deep temporal fascia, they had actually caught the fusion line at the temporal bone, and they deposited the product inside the skull. Patient didn't feel it. Next day, the patient came back with a rip-roaring headache, and when they did an MRI, they saw product sitting on the dura. Okay? So You can. That's one reported case that happens like that with the cannula. So you want to stay here because when you take a look at a skull, that's illuminated, where the light doesn't come through is up in this area over here where the skull is thickest. Okay? In that temporal region. I put my finger there to see if there's a vessel. I don't feel one. He's alive. Okay. I don't feel one over here. He's got a tan now. It's hard for me to be able to tell where his veins are. But to be honest with you, the worst that's going to happen is I'm going to go through them and be down on bone. If you're really nervous about that, you get somebody who's pretty white-skinned. You can bend them forward, let the veins engorge, mark them out, sit them back up, and go in between.
That's what I do. I do a Valsalva, bend them right over for 30 seconds, and then lift them up, and then you can mark out the veins easier that way.
So I'm down on bone now. Normally I would use a longer needle for this, but he gave me the BD2. I want to make sure that I'm touching bone. I want to make sure that I cannot get any deeper with this. I'm going to start the flow of product. You're okay, Ryan? Mm-hmm. Sure. As the product starts to flow, it's like dropping a pebble into water. It'll start to spread circumferentially. It'll stop at my fusion line because it's a fusion line. It'll stop at the orbital rim because it's a fusion line. It will continue up into the back of his hair over here because there's nothing to impede it. So I have to make sure that I put my finger behind to prevent that. Otherwise, I'm going to lose product. And the only place that it can go is where my pinky is moving down over here. So it's going to go exactly where I want it to go. I start the flow slowly. I'm watching the skin of the area. I'm looking over at the glabella, watching the skin of the area over here. And look how slow the plunger is moving. I'm moving the plunger very slowly and monitoring everything, okay? He'll hear things but not really feel them much. There shouldn't be much pain with that, is there, Adam? No. Okay? Mm-hmm. And we're almost finished. I'm going to put in the entire amount just because we're going to see what kind of effect it has. We're almost there, buddy, okay? It's when you're in a rush and you push hard that you get into issues. So same thing like when you're driving. If you're in a hurry, slow down. Drives my wife crazy. We're late for something, I drive slower. Not faster, because that's when you're going to get into an accident, and besides, it aggravates her, and I love it. Okay. So I'm going to pull my needle out now. I might have skewered a vessel, which I didn't. Okay? You're a lucky guy today. And then regardless of whether you get blood back or not, you put pressure on the area. Why? Because there's a deep vein there that's called the sentinel vein for my plastic surgical colleague over here and for my plastic surgical mentor over here. That deep vein, the sentinel vein, is what we use as an anatomical landmark to find the frontal branch of the facial nerve. It's down there, it's deep, it's very consistent. I might have gone through it and then put the product on bone behind it. He won't bruise now, but could be in a day or two, that blood that I go ahead, if I don't tampen at it now and put pressure, will rise up to the surface, and he'll get a yellowish-green discoloration over here, which he wouldn't be happy about. It's going to look like somebody hit him in the head. A female won't be happy about it because it's difficult to cover with makeup and they're going to have to wear their hair down. Remember, we're talking about experience. So I assume that I've skewered that vein every single time. And I just hold pressure. He's got two hands. Put him to work. He can hold pressure while you do the other side. Or if you have a nurse that's assisting you, she can come and hold pressure too. But because I'm busy yapping away here, I've just held pressure for 30 seconds, which is plenty if somebody hasn't taken any blood thinners with a 31 gauge needle, and then we're just going to take off the little bit that we have over here. And we're going to sit him up. We're going to get him to look into the camera over there. I'm going to try to balance his head again, and we see that the tail of the brow is kicked up on my side.
How much did we inject these 10 years ago? How much volume?
I used to put in a full cc of product. I don't ever do that anymore.
Or more.
Okay, so let me ask you a question, guys. Let's ask you a little question over here. Okay? He has a little bit of elevation of the tail of the brow. Now, here we get into conjecture. This is my belief, and we're going to see punch holes in it. But let me ask you a question. Why is the brow slightly up on that side, and why are we seeing now? This is what we want in the upper lid. Do you see the crease of his upper lid? You're seeing 2 millimeters or 3 millimeters of lid all the way around, and the other side is not showing that lateral little bit of lid. This is a more youthful look on this side. Why are we getting brow elevation from point what? 0.15 of a product that isn't really much of a lifter. Why is that happening?
Well, because you're smart and always treat the best side first.
That's number one. That is number one.
That is number one.
That is number one. When you're demonstrating, Okay? Always choose the better side first because you can impress the people more. I didn't even look to see which was his better side, but he is up more than what he started with originally if we were to look at his pictures from before. If you're in your office, by the way, choose the worst side first. Why? Because if you make the good side a 10 out of 10, you're really going to struggle to try to get that opposite side to be somewhat symmetrical. But if you bring a 7 out of 10 on the left to a 9, and this one's an 8, you only have to do a little more work to try to balance it out. You're going to end up offsetting patients. Here's my theory, and we're going to take a look if we see the same thing. He has a little bit of a scruff over here. We're going to see if we can do the same thing in the cheek. But my theory is the following. There is no elevator of the eyebrow in this area. This is a muscle of mastication. It's temporalis. Right? The only elevator over here is frontalis, and that's medial to the temporal crest where I didn't inject. And the product didn't go over there. And then people say, well, it's your lidocaine effect. I said, my lidocaine effect is down on bone, and if it was orbicularis, I'd have to be injecting superficially to get the vertical fibers of orbicularis. So how can it be happening? Well, this is why I'm doing a study right now to try to figure this out. Because my feeling is it's what I call the chair effect. When you put volume, this is myomodulation. When you put volume underneath a muscle or partially into a muscle, the muscle starts to relax a little bit, the same way that your back muscles are relaxing because you're sitting in a chair. That's why when you have a bad back, like I do, I'm wearing a back brace because it takes the strain off my back muscles. If I took the strain off the temporalis, why is his eyebrow going up? It means the frontalis is contracting. But why would it contract? This is the question that I couldn't understand because when you read the literature, there are no gap junctions between the muscles of the face. But that never made sense to me because how could you coordinate facial expression all from here? You must have some interplay or crosstalk between muscles. So we started putting in little electrodes into the forehead, very, very thin little electrodes for EMG to measure the background pull or the background activity of the frontalis. So the electrode's sitting here, I inject over here, and I start to see, not too long after the injection, I start to see the background activity of frontalis start to increase. So this muscle thinks that this one is relaxing. It has to take up the slack, but it has a different function. And you're going to see the same thing in the cheek. We put in just a small amount of product into the cheek, and if I hit zygomaticus major and I put it underneath zygomaticus major, I'll put in 0.2 cc's, you'll see the corner of his mouth start to come up. You can't tell me that's 0.2 cc's lifting. It can't be. It's the zygomaticus minor next to it that says, whoa, this guy's relaxed. I got to increase my pull, and you start to see the lips start to come up. So we're going to take a look at that in a second.
With subcutaneous injections, not even intramuscular. And they think it's a reflex, just a laxity in the skin.
There's so many different possibilities with that, but you got to think, and I think of it in terms holistically of the fact that what you're doing is you're restoring the platform to the way it was maybe 10 years ago, and there's muscle memory that says, hey, I remember that feeling, and it starts to realign the muscles a little bit. Very interesting comment. Thank you. Thank you very much. So any questions about the temple? Can you do the temple with a cannula? Absolutely. If you decide to do a temple with the cannula, his artery is doing this. I don't suggest you do it in this direction because you can catch the artery. Come from above down. Try to stay away from the hair. You can go from below up. You'll use more product. That's the downfall of using a cannula in this area. You'll probably use more product than I've used over here, but he wasn't a major temple issue. Okay, I got to get this right. There it goes. I just have to crank your head off. Okay, look straight. The camera's over there. We'll take a look. Okay. People say, does this last very long? You'll find that sometimes the eyebrow will look completely jacked up, and you get a little nervous about it. In a day or two, it starts to find its happy place, and it settles down. Okay? So you can do cannula. Advantage of cannula is you're coating over the vessels and you can remove the Tyndall effect of a very prominent vessel. Disadvantage of the technique of a single puncture is the fact that you're actually causing the pressure from below onto the deep temporal fascia where the vessels are lying, and you can get some engorgement of the veins over here that will last for about a day or two. So in a female, you might have to tell them to put their hair down to cover it, and when they massage it, it will settle out. Steve Fagan, my buddy that was here yesterday, does a lot of his temples by hyperdiluting his product and going in with a cannula and coating over it. He says they look boggy for a day or two. They have to massage quite a bit. He's thinking of changing over a little bit to more of my technique of doing it this way. But either way is fine, guys. Either way is fine. There's more than one GPS way to get there, okay? If you're comfortable with the cannula, go ahead and do it. Again, try to go across the vessel instead of in the direction of the vessel, because if you catch that vessel, you'll inject. There's been 4 cases of visual problems that occurred with temporal injections that happened here in the U.S., and 2 of them resolved, and 2 of them still have problems, one with partial, one with complete. Because that's a highway to go back in by over here, the trunk. You have to make sure you're down on bone. You must feel bone. If you don't feel bone, just don't inject. Okay? I'm sorry? I know that 2 of them were with needles. I don't know about the other 2. Okay. Let's look at the cheek in the male now. He's got a pretty good cheek. I did a pretty good job. When did we inject you? How long ago was that?
A year ago.
It's a year ago. Pretty good. I'm telling you, I should show you a picture of the way he was originally, because he was really a grade 4 out of 5 cheek loss volume type of guy. And we're going to take a look. Can I have a marking pen? And this is what Kent and I talk about. You look at the face and say, well, what does the face need? I know you girls would say a nice big kiss, but we're not talking about that. What the face needs, if we were to take a look at him, and he has nice volume over here, very little volume anteriorly. Maybe he has a little crease that's beginning over here. We'll see what we can do just a little bit to try to adjust this.
Yeah.
Do you agree with that, Kent?
Yeah.
And to me, he looks a little bit, you see how square he is and flat? There's really no curve to his cheek. So I have lost a little bit of what I try to gain on him. So I think we can also sort of fill him a little bit over here.
So you sleep on your left side?
Doesn't know.
Yeah, he sleeps on his left side. See, his nasolabial fold's got a crease. It's
Yeah.
also got flat.
He is a lefty, he said.
Yeah.
Okay.
Sleeps on his left side.
All right. So here we go.
I Sherlock Holmes the third.
Okay. So let's say that this is the volume that he needs in his lower face. What I'm going to do now is show you the anatomy that relates to this on the lower 2/3 of the face, so that you understand why we do the markings that we do. Okay? Can I have the red one? The main artery of the lower 2/3 of the face is the facial artery. The facial artery is a branch of the external carotid. The facial artery will come off the external carotid underneath the jaw over here, and it will run under the jawline. Okay? It's a branch of the external. It'll run under the jawline until it gets in front of the masseter. Can you clench your teeth for me? There, look at that beautiful masseter. Here's the anterior border of his masseter. You can relax now. And about 1 centimeter in front, I have my finger on his pulse. That's the facial artery. So it's coming over that area right there. It's going to enter the face right there. It's pretty consistent, being about 1 centimeter, 1.5 centimeters in front. And then it does this crazy thing where it does this as it heads towards the corner of the nose. It wiggle-waggles its way all the way up. We haven't got anything that works a little better than this? Can you give me another color? Here, what's this?
That one you're using doesn't show up too much, Arthur.
No, that's for sure.
Last one.
So we'll try this. Okay? It's the most tortuous vessel in the face. Why is it the most tortuous vessel in the face? Can you open your mouth all the way, Ryan? Because it has to act like a spring. It's a thick vessel. And if every time you opened your mouth, that's great. If every time you opened your mouth, your face would blanch, it would be kind of embarrassing. The vein, on the other hand, I'll take a blue one. Thanks, Lorraine. The vein, on the other hand, even though it is the thickest vein in the face, is still much thinner walled. And it takes a straight course like that. Boy, the blue works great. And it's one of the few times that we find that the vein doesn't run with the artery. They usually run in pairs. And when you do microsurgery, if you want to connect into this, you have to find the vein which is sitting inside the bulk of the masseter at its anterior portion, and the artery just in front of it. So the problem is I don't know whether the vein is doing a nice circuitous thing like this. I don't know whether the artery is turning left instead of right when it goes up. And the answer is, I don't care, like Ken says. Tell somebody who cares. What do I care about? Absolutely. If it's deep, I'm injecting superficial. If it's superficial, I'm injecting behind it deep. And luckily for us, those vessels are running very deep. They're sitting on bone here just about, okay? and all the way up to the bottom part of the bone. That's where the other part of it, that's feeling the bottom part of the bone here, in this area right over here, to here, to here, to here, those vessels are passing underneath the muscles of expression. They're passing underneath rhizorius. They're passing underneath zygomaticus major. Most of the time under zygomaticus minor, sometimes flipping over it, but I don't care because it's up over here. And in this area, they are running deep. They're lying on buccinator. That's the muscle that lines the inside of your mouth. It's the muscles that frogs use to call their mates. Right? They're deep. I'm going superficial. And to make sure that I'm really superficial above them, I'm increasing my safety by pinching the skin out and doing this. When you distract the skin of the cheek, the inside of the cheek, let it move. Put your tongue on it. Pull it. So what you're doing is you're adding in an extra centimeter half of safety, and you can fire into, with a needle or a cannula, into the subcutaneous tissue over here. And that's where I keep all my injections superficial, except for the gonial angle, which we'll talk about, not on him, but on our next patient. So this is a big S for me. It's superficial injections. Okay? That could be 3 millimeters under the skin. That could be 5 millimeters under the skin, but I ain't going any deeper than that because you're going to hit a major vessel over there. Okay? Now we come to this area outside the outside part of the iris. I'm going to stick with this color because it works well. Outside the outside part of the iris, the main blood vessel supply over here is by an artery called the transverse facial artery. It's also a branch of the superficial temporal. As it comes off underneath the zygomatic arch over here, it gives off a deep branch. Do we care about that?
The terumas that come
No, because we're injecting. Right. And it gives off a superficial branch that does this. It arborizes. It sort of matches up with all the veins over here. So our risk over here is bruising.
Define
Perfect.
with the teruma.
Great. Our risk over here is bruising. Right? When you get to the medial aspect over here, so I can inject on this area superficial or deep. Okay, I can do either one. Because my risk is going to be bruising. It's very unlikely that you're going to find a vessel that's going to be a direct link going all the way up to the supratrochlear through the angular. Usually you'll end up somewhere in the infraorbital artery. Possibly. So you can inject superficial or deep. We'll talk about that, why you would choose superficial or deep in any patient. Just think about it for a second. The deep fat over here, called the SUF, is underneath the orbicularis muscle. That deep fat is there to prevent the muscle from shearing and wearing away on the bone. It's there to make a coating so that the muscle can glide, because we have muscles of facial expression there, right? That fat is attached to bone so that if you inject into that fat, the product stays there. The rest of the fat, which is over the muscle, the mobile fat pad of the face, is exactly that. When you smile, you drive it up. So if you wanted to get this type of look, you can inject superficially with a lot of product. We don't want that. If you want to contour the cheek, you can inject deeper. Okay? So now I'm going to inject this area before we get into, and then there's the medial aspect over here. Why do I make the line of demarcation at the lateral iris? Because I'm worried about the infraorbital artery, which isn't as consistent as its brother up over here, the supraorbital artery. The infraorbital artery in 80% of cases will be lined up with the inside of the iris as well, but 5 to 8 millimeters below the orbital rim, which allows you to put product on the orbital rim safer. Not 100% safe, but safer. That artery, as it comes out over here, wants to supply the overlying tissue. It's not as fixed in location as this one, and it actually can come out at the mid-pupillary line, so I gave myself a little bit of extra window of safety. So this area I can inject with a needle, superficial or deep. This area, I don't know the depth of the artery as it comes out, so I'm using a cannula. I think if you wander into this area with a needle, you're asking for trouble. That's my own personal opinion. This is cannula country. If you're not used to using a cannula, get used to using a cannula. Because if you sit down and eat with a fork all the time, you're going to miss out on some beautiful soups. You have to become good at using whatever there is available to us, and you should be able to, and it's a very quick learning curve. So cannula to me, except for the orbital rim over here, you can use a needle on that if you want, but cannula to me is the way to go, and it's a lateral approach. Why is it a lateral approach? Because the artery doesn't come out straight out like this, it comes out at a 45-degree angle. And that keeps a little, if you look at a skeleton, a skull, you're going to see a little hood of bone over that foramen. And that protects the artery and the nerve because it's coming out like this. If you come from a lateral approach, you cannot get inside that foramen because it's being hooded. It's protected. It's got a little umbrella over it. But if you come from an inferior approach like this, you're going to find that foramen every single time. It almost funnels in right there. So I don't like to see people injecting like this. Where Kent was injecting was at an angle which is fine like this or an angle like this. Okay? So